Aloha, everyone. Welcome to Queen's Free Speaking of Health lecture series. Tonight's lecture is called Modern Management of Stroke in 2019. I'm Mina Sugimoto from the Corporate Communications Department at the Queen's Health Systems, and on behalf of Queen's, I welcome you all here this evening. I would like to introduce our speaker, Dr. Ronnie Salem. He is a vascular neurologist and neurohospitalist at the Queen's Medical Center. Dr. Salem was raised in Los Angeles. He has a Bachelor of Science from the University of California, San Diego, and earned his medical degree at New York Medical College. He did his neurology residency at the Kaiser Permanente Los Angeles Medical Center and a stroke fellowship at Boston University Medical Center. He is an assistant clinical professor of medicine in the Division of Neurology at the University of Hawaii John A. Burns School of Medicine. A warm welcome, please, for Dr. Salem.
Okay, good evening, everyone. Thanks for being here. So today we're going to have a talk on stroke management and kind of the advances and new developments that are happening in the stroke world. So we're going to kind of cover a lot of information today, and I think you're going to learn more than you ever thought you'd need to know about stroke, but I hope you find this information useful. So just a brief outline on what we're going to talk about today. So I'm going to just start with some basic, what exactly is a stroke? What are the signs and symptoms of a stroke? Who's at risk for having a stroke? And what can be done for you when you have a stroke? And then what can you do for yourself after the stroke is done? So just a little bit of kind of basic knowledge just to lay a foundation. So what is a stroke? Surprising, a lot of people are not exactly sure what that means. So when I say a stroke, a way of thinking about it is it's kind of like similar to a heart attack. It's a brain attack. And a stroke is an acute neurologic injury to the brain due to either too much or too little blood. And it can lead to permanent neurologic deficits depending on which part of the brain is affected. So if you look at the picture I have up here, so there's really two main categories of stroke. Majority of what we're going to be talking about today is ischemic stroke. So that is a stroke from a blood clot. And so as you can see the picture there, a blood clot leads to a blockage of blood flow to a specific part of the brain. And so therefore that part of the brain is not getting any blood or oxygen, and then the brain cells quickly begin dying. So then the symptoms become apparent very quickly based on which part of the brain is affected. The other type of stroke is the opposite. It's a hemorrhagic stroke. That is when a blood vessel bursts. So rather than too little blood, there's bleeding within the brain, and then it's that bleeding that causes the neurologic injury. So that's kind of a quick categorization of the two main subtypes of stroke. So just to kind of paint a picture of, really how prevalent of a disease this is, and really, how big of a problem this is worldwide. I'm going to just share a little bit of statistics just to give you an idea. So here in the United States, stroke is the leading cause of disability, and it's actually the number 4 cause of death, and actually worldwide, it's the number 2 cause of death. And about 800,000 people per year have a stroke here in the United States. And so surprisingly, about 75% of those, so 600,000, have had a stroke in the past. And that's going to be, you're going to see why that's very important, because once you have one stroke, you are susceptible to having more strokes, and that's where a lot of the treatment comes into play. About 130,000 people die of a stroke every year in this country, and one person dies from a stroke every 4 minutes, and one person has a stroke every 40 seconds. So it really shows you how devastating and prevalent this disease is. So a little bit more statistics, over 1/3 of people who have strokes are younger than 65 years old. So this is actually, contrary to popular belief, not a disease of the elderly. Strokes really can happen at any age. Similar rates between men and women are seen in strokes, but once you get past 75 years old, women actually tend to have a slightly higher risk of strokes. And there's actually some ethnic variation as well. We see higher rates of stroke in blacks, Hispanics, and people of lower socioeconomic status. And there's actually a big financial burden to strokes as well. It's really not just the healthcare costs, but About $40 billion per year are spent on stroke, also factoring in amount of work lost from people having to miss work because of the disability that comes with having a stroke. And that's really the main issue with strokes is the long-term disability. The good thing though is it's estimated about 80% of strokes are preventable. And that's really why understanding, what can cause stroke, what the treatments are is really important, because there's a lot you can do to really minimize your chance of having a stroke. So I'd like to show this graphic here. This is a map of the United States that's showing different mortality rates from strokes. And the darker the purple, the higher the mortality rate. So if you look down there in kind of the southeast portion of the country, a lot of people call that the stroke belt, because that's where the highest rates of death from stroke are. And a lot of that has to do with they just have a much higher rate of diabetes, high blood pressure, cholesterol, a lot more fried food down there. If you look down here in terms of the box on the right, you can see Hawaii. The purple is a little bit more in the middle. So Hawaii is not doing great, but doing better than a lot of other places in the country. So it just kind of shows you how stroke affects different geographic regions differently as well. So here in Hawaii, stroke is a big problem here as well. Accounts for about 8% of all deaths in the country, and it's the in the state, and it's the number 3 leading cause of death in Hawaii as well. And interestingly, Native Hawaiians and Pacific Islanders actually are 4 times more likely to die from a stroke than whites. And Native Hawaiians and Pacific Islanders also have strokes at much younger ages on average, around 10 years. So it's actually a very big difference. And a lot of that is felt to be from higher incidence of diabetes, high blood pressure, and obesity here. And part of that also is access to health care, especially on some of the outer islands, and methamphetamine use, which is a big problem here in Hawaii. So those are some of the differences compared to the mainland we see here in Hawaii. Okay, so now we know what a stroke is. We know how prevalent it is. So I'm going to talk in a little bit more detail. So in terms of ischemic strokes, again, these are the strokes from blood clots. These are by far the more common types of strokes, and they account for about 87% of strokes. And again, this is a stroke that is from a lack of blood to a specific part of the brain from a blood clot. And so this picture is just an illustration of one of the imaging modalities that we use in the hospital, a special type of imaging where we can look at the blood vessels and blood flow in the brain. So if you look at the picture on the left there where the arrow is pointing, all of a sudden you see a sudden cutoff of blood flow. And if you compare it to the picture on the right, all of a sudden you're seeing all this blood flow out into the periphery. So that picture on the left, that's where the blood clot is. So the blood clot is suddenly stopping all that blood flow. It should look like the picture on the right. So as you can see, that's the kind of damage that can happen from a blood flow. That's one of the major blood vessels in the brain. So a blood clot there would lead to a very large stroke. And so this picture here is just an illustration just to give you guys an idea of what we're looking at when we get a CAT scan on a patient. Just to give you an idea of what a stroke looks like on a CAT scan. This is a very large stroke. So if you can see the area on the left of the pictures in both CAT scans is much more gray compared to the other side. So that's actually illustrating a very large stroke. And if you compare it to this, now this is where the arrow is pointing, is showing a very small stroke, that small gray area. So again, these are strokes from blood clots. So the gray area is essentially dead brain tissue. That's what we're looking at on the CAT scan. And now, so hemorrhagic strokes, again, remember these are strokes from burst blood vessels where you're having bleeding into the brain. And these are not nearly as common as strokes from blood clots, but they still are very frequent. They account for about 10% of strokes here in Hawaii. And one of the clues that a stroke might be from bleeding rather than from a blood clot, oftentimes you might see a headache or vomiting accompanying the stroke symptoms. And even though we only see it about 10% of strokes here in the States, we do know that different ethnic populations, we see it much more common. So for example, Asians have a much higher incidence of hemorrhagic strokes. So for example, in Japan, rather than 10%, about 25% of all strokes are from hemorrhages. And hemorrhagic strokes are a lot more deadly. About 1/3 of people who have a hemorrhagic stroke will die within 3 months. So these are very dangerous types of strokes. And this picture kind of is an attempt to illustrate why they're so dangerous. So if you remember the last CAT scan I showed, all the area that was damaged was all gray. That was dead brain tissue. What we're seeing on this CAT scan is all this white stuff is actually blood. And if you look at the picture on the left, that is a stroke from a burst blood vessel 2 hours after the blood vessel bursts. We're seeing a lot of blood, and we're seeing a little bit of the brain being pushed to the other side, but not that bad. But the reason these strokes are so dangerous, if you look just 4.5 hours later, the same patient, the CAT scan, there's about double the amount of blood there. And now you're seeing a lot more of pressure effect on the brain. The other side of the brain is being pushed over. And this is why these strokes are so dangerous and why they can be fatal in the very early period. So again, very different type of stroke than from a blood clot. And again, this is another CAT scan showing another type of hemorrhagic stroke. So again, the white you're seeing there is blood, and so it's much smaller than the other one. And the interesting thing when we look at strokes on CAT scans, oftentimes we might see strokes that look very similar. And really strokes are all about the location and the size. So we might see, strokes that look the exact same, between two patients, and those patients might have very different severity of symptoms. And it just, a lot of that has to do with just the variability from person to person. I always tell people you might see 5 patients with the exact same CAT scan and they all have a different degree of symptoms. So there is a lot that, we can't predict, and there's just some inherent difference from person to person. So we kind of have a better idea what a stroke is. So now, and this is what's really important for you guys to know is how do you recognize a stroke? One of the common problems we see in the emergency room and in the hospital is people getting to the hospital too late for us to be able to really, offer some of the treatments that can really make a difference. And so that's why there's been a lot of public awareness geared towards trying to make the public more aware of how to recognize the signs of a stroke and what to do when you recognize them. And it's gotten better over the years, but it's still, majority of people still get to the hospital too late, actually. So some of the common signs of a stroke, a way that we think about it is strokes usually affect, the majority of the time one side of the body. So you're looking for some type of asymmetry. So some type of loss of function. The most common signs we'll see are, one side of the body not moving as good as the other side, or you can't feel as good on one side of the body as the other side, meaning it's feeling numb, you're losing sensation, you're having trouble speaking, so you're losing the ability to do something. So that's a kind of a general way to think about. If you're having a symptom, you're not quite sure what it is, that's one way to think about it. That could be potentially a sign of a stroke. So those are the obvious signs, but there are a lot of kind of more subtle signs of stroke, and these are really the stroke patients that end up coming to the hospital late, because sometimes it's not obvious. Sometimes the symptoms are very mild or not that bothersome to the patient. So for example, if you're just noticing that you're walking and you suddenly are feeling unsteady on your feet and you're just off balance, that actually could potentially be a stroke. Some of these symptoms are what we call non-specific symptoms, meaning they could be from other things too, which is part of the reason that people might show up too late to the hospital. Visual symptoms could be a sign of a stroke. So if you suddenly lose peripheral vision on one side, if you suddenly start seeing double, those are other signs of stroke as well. Something as subtle as some clumsiness of your hand, a little incoordination of the hand. So if you notice you're dropping things out of one hand, your handwriting is not normal, you're having trouble buttoning a shirt, that actually could be a sign of a mild stroke. Difficulty reading as well. So there is a type of stroke that could make you able to, look at a word and pick out what the letters are, but not actually know what the word is. Your brain cannot process how to read a word, actually. That actually could be a sign of a stroke as well. And vertigo. So that's when people say vertigo, that means you feel like the room is spinning, you're very dizzy, and that actually could be a sign of a stroke. That's a tricky one, even for healthcare providers, because oftentimes it's hard to tell, because it's more common that vertigo, that dizzy feeling, is actually from an inner ear problem. And, and if it is, I mean, it's still very uncomfortable. It can lead to really severe dizziness and vomiting and trouble walking, but it's actually a benign condition. It's not dangerous at all if it's an inner ear problem. But the problem is it can be a symptom of a stroke. So if you've had vertigo many times before and you're having it again, it doesn't mean you have to call 911 and rush to the hospital if you've had it before. But if you've never had vertigo and it comes on all of a sudden, that could potentially be a stroke symptom. So it's important to know, like as I've kind of alluded to, no two strokes are alike. The symptoms all depend on which part of the brain is affected, how large the stroke is. But kind of a rule of thumb is that stroke symptoms usually happen suddenly. So that should be a clue. If you're normal, you're feeling fine, and all of a sudden you're feeling one of these symptoms, that should kind of raise a red flag that might be a stroke symptom. And some of you may have seen this or a variation of this advertisement. So this is something, the F.A.S.T campaign. This is like the public awareness campaign of the American Heart Association. That's been, they're using to try to raise public awareness on how to recognize stroke signs. And so the acronym they use is F.A.S.T, and that stands for stands for face. So if you're wondering if you or a loved one might be having stroke symptoms, if you ask them to smile and one side of their face is drooping down, that could potentially be the sign of a stroke. The A stands for arm. So if you have both arms up and one of them is drifting down like this, that could be a sign of arm weakness, which you can see with a stroke. The S stands for speech. So if you ask them to repeat a sentence and they're slurring their words or they just cannot get the words out, that should raise an alert to you that could be a sign of a stroke as well. And the T stands for time. So that's really, as you can already kind of get the sense, I'm really hammering home the point of how important time is. And that's because if you recognize any of these symptoms, you have to call 911. And because the sooner you or the patient gets to the emergency room, the better chance they have of the brain cells being saved and the stroke being reversed. So again, if you suspect a stroke, do not drive to the hospital. Call 911. A lot of people make that mistake and drive to the hospital. And the reason, even if you feel like, oh, I live really close, I can drive in, the other reason it's important to call 911 is the ambulance can alert the hospital that you're on the way. That allows us to get ready, to get the team ready to open up the CAT scanner, and it really speeds things up to allow us to get everything moving quickly. And we always say time is brain. About 2 million brain cells die every minute at the onset of a stroke. And so as you can see, like the minutes really matter. When we are asking patients and family members, we're really asking them down to the minute when this started, because we know that, the time between when the symptoms started and when we can actually offer treatment, brain cells are actively dying. So again, that's really why the time is so important when it comes to stroke. So now, who's at risk of having a stroke? Some of the risk factors might be obvious, some not so obvious, but it's really important to know them because this is how you can give yourself or your family the best chance of preventing a stroke. Some of the most common risk factors for stroke are what we call vascular risk factors, meaning risk factors that put you at risk for vascular disease. So a lot of these risk factors are very similar to the risk factors for heart attacks, for example. So high blood pressure, diabetes, high cholesterol, those are the three main ones. Everyone probably knows about that, but those are also the most important ones because they're so common and can lead to really significant strokes. Obesity also increases your chance of having a stroke. Poor diet, lack of exercise. So a lot of these are also just healthy, lifestyle choices. So if you're not living a healthy lifestyle, a lot of those things can accumulate and increase your risk of having a stroke. Not being physically active, smoking tobacco, heavy alcohol use and drug use, and I kind of alluded to the methamphetamine use, which again we see it in Hawaii a lot. So we see a lot of young people having strokes. And then there are a lot of other causes of strokes people may not be as aware of. So atrial fibrillation, that's a type of irregular heartbeat. That's actually very common and actually notorious for causing strokes. And obstructive sleep apnea. So obstructive sleep apnea is when you actually have periods of time when you're asleep, when you stop breathing. That actually can increase your risk for a stroke as well. Certain neck injuries can increase your risk for a stroke. A neck injury can cause an injury to a blood vessel that can lead to a clot traveling up to your brain. So we've seen this in severe neck injuries from car accidents or bad falls, and seen it from things as subtle as someone going to the salon and having their neck hyperextended for a long period of time, or like hyperextension of the neck is really the thing that puts you at risk. A PFO, so that stands for patent foramen ovale. I'm going to talk about that a little bit later in the talk, but briefly, that's a hole in the heart that a lot of people are born with, actually, and most of the time, don't cause any medical issues, but in rare situations can cause strokes. And certain blood clotting disorders that can be genetic, and certain autoimmune diseases like lupus, for example, can actually lead to strokes. And cancer. So a lot of people don't know that, but having cancer increases your risk of having a stroke because cancer makes you prone to clotting, not just in the brain, but other parts of the body. And then I kind of mentioned the drug use as well. So, as you can see, that's a really long, and that's not even a complete list of all the risk factors for stroke, but those are the main ones. And there is a cumulative effect. So each one of these risk factors brings your odds of having a stroke higher and higher. And the reason it's important to know that is the opposite is true as well. So addressing and treating each one of these risk factors lowers your risk more and more. So as you can see, just choosing to live a healthy lifestyle will go a long way towards preventing a stroke. So limiting your salt intake, sugar, fat, exercising, not smoking, that's going to go a long way to reducing your stroke risk. And then taking medications as prescribed to you for these different risk factors also is going to lower your stroke risk. So I usually tell patients, the one thing you can't control is your age, but you can control most other things. And a lot of these risk factors, we call them modifiable risk factors because you can change them. You can control your blood pressure, you can get your blood sugars down, so that's why that it's really important to address each one of these possible risk factors. And the mistake I see a lot of people make is, after they have a stroke, they'll go on their medication and they think they're done and they don't have to worry about anything anymore. But, it's a lot more involved than that. It really takes a lot of buy-in by the patient to be, take charge of your health. So I like to show this graph because this kind of illustrates what I'm talking about. Basically, this is a graph showing the estimated 10-year risk of having a stroke in a 55-year-old patient. And so if you look at A, B, C, D, E, and F, so what this is showing on A, so the blue is men and the red is women. So column A is a 55-year-old patient who's healthy, has normal blood pressure, does not smoke, doesn't have diabetes, and that's their 10-year risk of having a stroke. So we're talking 1 to 2%, so very low risk. And now what this graph is showing is the additive effect of each risk factor. So that same person, if they develop high blood pressure, then you look at column B, now their stroke risk goes up, almost more than double. Now we're talking 2 to 4%. The next column over, now that same person, they develop diabetes, their risk goes up even more. They smoke, it goes up more. And then now let's say they develop an irregular heartbeat like atrial fibrillation, which actually is a complication of high blood pressure, for example. Their risk more than doubles. So this really just shows the additive effect of these risk factors. And like I said, controlling these risk factors, you can get the numbers to go back down. So that's why it's really important to work very closely with your primary care doctor and make sure you have one and are seeing them regularly. I see a lot of patients that do not have a primary care doctor. Making sure you're taking your medications and having some sort of structure I found to be very helpful. Having some sort of diet plan or an exercise program. If you're a smoker, finding some type of smoking cessation program. So just, making sure to find a way to tackle all these risk factors. So blood pressure especially, I'm going to talk about certain treatments for stroke, but one of the most important things in stroke prevention is blood pressure. And so this is a blood pressure machine. That's what I'm showing here. And the reason I'm showing it is I tell all my patients to get a blood pressure machine and have it at home so that they can check their blood pressure regularly. When you go to the doctor's office, your doctor is only seeing your blood pressure at that moment. If you have a machine and you are logging your blood pressures, you're checking them every day, your doctor will have a much better idea of if your blood pressure is controlled or not. And so that's really crucial, I think, to being able to not just control your blood pressure, but allow your doctor to make an informed decision on if he needs to adjust medication, etc. And same idea, so if you're diabetic, this is a finger stick to check your blood sugars. So again, just showing that these are things that you need to be monitoring at home, and you cannot rely on your doctor to manage this. He can help you, but you need to also be the one keeping track, because you're the one that's giving him the information to make a decision. And so I kind of mentioned obstructive sleep apnea earlier. So again, this is a condition that's actually very, very prevalent in society. Most people don't know they have it and are not diagnosed. It's essentially caused by partial airway obstruction. And what happens is when you're sleeping, if you have this condition, you have brief periods of time where you actually stop breathing and you kind of gasp for air. And you may never know you have it, because the most common symptoms are snoring, which, maybe your partner might tell you you snore really loud, and then you might just have daytime sleepiness, so like really fatigued. So kind of non-specific symptoms that you might not think much about, but the reason it's so important is this is a condition that can double the risk for a stroke. And there's also an association with sleep apnea and high blood pressure and atrial fibrillation. And it's not just it's more common in obese people, but it's not just a disease of obese patients. That's what the misconception a lot of people have. You can be extremely thin and slender and have sleep apnea. So really, anyone who has a stroke, we recommend they get screened for sleep apnea. And even if you've never had a stroke, if you're finding yourself always tired during the day, if you're known to be a loud snorer, it might be a good idea to have, to get checked. And the way they test you for this is by doing a sleep study, where they basically have you sleep in a sleep lab where you're and they hook you up to a bunch of wires. It's not the most natural sleep environment, but they kind of measure your breathing patterns, your heart rate, and monitor you for a night. And if you have sleep apnea, again, this is a modifiable risk factor. This is a treatable condition. So you can see this is called a CPAP mask or a CPAP machine. So it's basically a mask that you wear while you're sleeping that pumps in continuous oxygen to prevent those periods of time where you stop breathing. And you see the one on the left kind of looks really bulky and annoying. A lot of people don't like wearing it. They do have smaller devices these days. So the one on the right, that's called a nasal CPAP. So if you're claustrophobic or you just can't sleep with that thing, there are other masks that you could try potentially. So again, kind of going towards risk factors and just healthy lifestyle choices. So the Mediterranean diet I usually mention. Some of you may be familiar. It's been in the news a little bit recently. I think they ranked it the healthiest diet in the world, actually, in on an article I saw recently. But we've been recommending it for a long time because it's actually the only diet that's been shown in clinical studies to reduce the risk of stroke. And it also has a lot of other health benefits in terms of heart health. It improves brain function in terms of your memory, your problem solving, and it's really a diet that it's not a very strict diet like some other diets. It does have some leeway. So the mainstays of the diet, it's a lot of greens, fruits, vegetables, a lot of olive oil, nuts, seeds, grains, beans, lentils, but then it also allows you some dairy, some lean protein like fish and chicken. And if you look at this kind of food pyramid, like even, you can have a nice steak, on occasion, like once a month. So it's not an extremely strict diet, but it's actually very healthy if you follow it properly. Okay, so we kind of talked a lot about, what is a stroke, what are the types of strokes, what leads to a stroke, what are the risk factors that lead to a stroke. But let's say you do all these things and you or a family member actually has a stroke, and you're able to recognize it, call 911, and get to the emergency room quickly. So what can we do when you get to the emergency room? So really the mainstay of stroke treatment is for the last 30 years or so has been a medication called TPA or ALTEPLASE. This is a clot busting medication. It is the only FDA approved medication for the treatment of an acute stroke. And it's basically given intravenously over an hour. And one of the big breakthroughs actually, recently in stroke treatment is that we can offer this treatment in a much later than we used to. So 10 years ago, we could only give this medication in the first 3 hours after a stroke. And then they did some more studies and they found that actually we can give it up to 4.5 hours after a stroke. Actually, and then just a couple months ago, they've actually expanded that time window now, not for everyone, but to select patients depending on certain characteristics of their CAT scans, but up to 9 hours now. So that's allowing us to offer this treatment to a lot more patients. So a lot more patients that, and again, and it's important because you see a lot of, as I mentioned, a lot of people come to the emergency room late. They're not recognizing the symptoms, or maybe they wake up with the stroke, and waking up with the stroke's always been a problem as well because, it's hard to know when the stroke actually happened if someone wakes up with symptoms. So now, now that we can offer this up to 9 hours in some patients, we can really, help a lot more people to try to, prevent them from having some permanent long-term disability. Because it is a clot busting medication, there is a small risk of bleeding, about 3 to 6%. And that bleeding is potentially bleeding in the brain or anywhere in the body. So we are very careful about who we give it to in terms of if they are considered to be a high bleeding risk. For example, people who are, who have certain types of already known bleeding disorders, or who are on certain types of medications, or who may have had a recent major surgery, like an open heart surgery, something like that. We might not be able to give them that medication. But it has, it has helped a lot of patients because what it does is dissolve the blood clot that's causing the symptoms. And as we saw how important time is, if you can get that clot dissolved before more and more brain cells die, you're really, preserving a lot of brain function. So it actually increases the chances of having a good functional outcome. And what I mean by that is, being independent after a stroke. And again, the earlier you get it, the better chances you are of having that better outcome. And it actually, in some patients, has the potential to completely reverse the effect of the stroke. And we see this all the time in the hospital in some patients. If they get there early enough, if the clot is the right size, that you give the medication and within an hour or two they're back to normal. So it happens. But what we know is that TPA is not as effective for really large blood clots. It can help sometimes, but it's not as effective for the large ones as for more medium-sized or smaller blood clots. And so that's where endovascular therapy comes into play. So there's a procedure we use called mechanical thrombectomy. And what that is, it's a type of clot retrieval procedure where we take a catheter wire and we puncture the groin, and using live X-ray, the groin or the wrist actually in some situations, and then we use live X-ray and to see and actually track that guide wire all the way up through the blood vessels, up all the way to the brain, and then at the end of that wire is a device that can actually physically pull the clot out. And obviously, this is a treatment that we can really we offer for severe strokes. So if you have like a very minor stroke, this is not something that is gonna apply to you. But this is a procedure we can do to someone who's having a severe, devastating stroke that untreated is gonna leave them disabled permanently or potentially die from. And up until just a couple years ago, we could really only offer this treatment up to 6 hours from the time of the stroke. And actually, it wasn't even an FDA-approved treatment. There was actually no clinical studies that had proven that it was beneficial, even though we knew it was a beneficial treatment. The problem was we didn't know which patients to offer it to. And so up until 2 years ago, we had to tell families that this is an experimental procedure we're doing. We don't know if there's a benefit or not, but we think it might help. So that's changed. That's all changed now. A couple years ago, there's been a lot of studies now, countless studies that have come out proving its benefit. And then last year, we actually have new data that's come out that allows us to offer this treatment up to 24 hours after the stroke onset in some patients. So we use advanced imaging to try to select the patients that will benefit from this procedure. And this really has helped us, like as I mentioned, with patients who wake up with strokes. We call these wake-up strokes because we don't know when the stroke happened. So in the past, we would have to assume that the stroke happened right before they went to bed because we couldn't take the chance of being wrong and having them bleed. So now we can, if we get them in and they wake up with a stroke and we do this advanced imaging and they meet the imaging criteria, we can offer these patients strokes. And then there's a lot of patients who have strokes where we don't know the time of onset. Maybe the family comes and finds their loved one on the floor in bed with a stroke, and they don't know when it happened. using these imaging techniques, we can actually still offer treatment to some of these patients when before we would never be able to. So this is really the technology we're using now. This is called a CT perfusion scan, and this is actually like software generated image. So we get these pictures within minutes after we do the CAT scan. When we're sitting in the CAT scan room with the patient, we get these images immediately. Actually, they come to us by email, and then what you're looking at is on the left, all the purplish pink area. So that's the parts of the brain where the stroke's already affected. So that's already permanently damaged brain tissue. But if you look at the pictures on the right, all that green area, that's the area. It's much larger than the purple. So that's the area of the brain that's still what we call salvageable tissue. That's brain tissue that is at risk of dying if you don't pull the clot out. But if you can pull the clot out quickly enough, you might be able to save those parts of the brain. And you can see down there this special CAT scan pumps out numbers for us. It'll tell us the number of milliliters of brain tissue, the volume of brain tissue affected, will tell us the ratio, and then we can use those numbers to decide whether or not the patient can get the treatment. So that's really changed the way that we kind of triage patients when they come into the emergency room. So if we do end up offering this treatment, this is where the patient goes. This is an angio suite, and this is where they will go and get this mechanical thrombectomy procedure. And you can see the screens up there are kind of where the operator is, the physician is looking to see exactly where the wire is as he's tracking the wire up to pull the clot out. And these are kind of the pictures he's looking at. So if you look at the box on the upper left, that's at the beginning of the procedure. You're going to see that's the blockage of the blood vessel. And then as the procedure goes on, the goal is to achieve what you're seeing in the bottom right corner, opening up that blood vessel and getting the blood flow back going to that side of the brain. And that's really the goal of the procedure. And just like with the TPA, in some patients, this can lead to pretty quick improvement. So I'm going to show a quick video just to kind of give you an idea of kind of what the procedure looks like, actually. Just kind of an animated video. And this is one specific device that's used, but there are different types of devices that actually we use to pull clots out. This is a specific one. And so you can see the blood vessels here. So there's the clot. And those major blood vessels are kind of right behind the eyes. And again, we're entering through the groin and moving that wire all the way up to the brain. There's the wire going up. The wire goes past the point of the clot, and then this specific device is just going to suck the clot out like a vacuum almost. There are other devices that work like stents, where they will actually just pull the clot out, but this is almost like an aspiration type device. And like I said, there's a lot of different devices on the market, and so the people that do this procedure will choose the device depending on the individual situation. And the clot gets pulled out, the wire gets pulled back out, and comes out of the leg. And if everything goes well, this procedure doesn't take very long. It can take less than an hour, and sometimes less than half an hour if everything goes smoothly. So that's what we can do in the emergency room in those first few hours if you get there quickly enough, if you meet the criteria. Those are the two main treatments for the acute period. So what about after that? After the stroke happens, the patient gets admitted to the hospital. The next important thing is to try to figure out what actually caused the stroke, because that's really going to be very important in terms of helping us try to figure out what's going to be the best way to prevent a stroke. Because there are many different causes of strokes, and they all have different types of treatments that we might have to offer. So this table is just kind of giving an example of how large of a variety there is of different causes of strokes and how different the treatments can be. So for example, if you have a stroke because of a problem with plaque buildup and blockage of an artery in your neck, sometimes we'll have to do surgery to clean that out. And then sometimes if you have a a narrowing of a blood vessel in the brain, we treat that with, a combination of blood thinners. If you have an irregular heartbeat like atrial fibrillation, we use different types of blood thinners. Let's say you have atrial fibrillation, but it's unsafe for you to take these blood thinners because blood thinners come with bleeding risk. So what if you cannot be on blood thinners? Then you can be considered for a certain type of heart procedure called left atrial appendage closure, which I'm going to talk about in a minute. So that's something that could be an option as well. And what if your stroke is from a PFO? So remember, the PFO is that hole in the heart I mentioned. So there's a procedure where you can get that hole sealed up and closed, actually. So as you can see, that's why when someone comes to the hospital, the reason we do a lot of tests, the testing is really not to cure them or fix the stroke that just happened. It's to prevent the next stroke from happening. And so again, in terms of if you have one stroke, your risk of having another stroke statistically is higher. So that's where a lot of this risk factor reduction comes into play. So it's really the same rules apply from what I was talking about before. If you have high blood pressure, it needs to be controlled. Cholesterol, blood sugar, all the same risk factors, but it's even more important now because now you know that you're susceptible to stroke, you've had it happen, you're at a higher risk of it happening, so it becomes even more important to control these risk factors. The common mistake I always see people making is, for example, if they have a stroke and we find out it's a blockage of the artery in their neck and they get surgery, they think, oh, they fixed it, I don't have to worry anymore, and then they stop paying attention to the blood pressure, stop paying attention to their blood sugars, they stop watching their diet, and again, that's a big mistake because, like I said, each of these risk factors contributes. Fixing one thing doesn't make you immune to having a stroke. You have to address all of them. The next big thing, though, after you have a stroke is blood thinners. So all these risk factor control is very important. Controlling the blood pressure, if you need medication for all those things, is crucial. But if you've had a stroke, you need to be on blood thinners, again, unless it's unsafe for you, and that's something that your doctor would discuss with you. But if blood thinners are very important in terms of preventing a stroke, because again, the strokes we're talking about here are strokes from blood clots, and the blood thinners are to prevent blood clot formation. So the two main categories of blood thinners are antiplatelets, and those work best for strokes from like plaque buildup in arteries. So aspirin being the most common one you're probably familiar with, but there are other ones like PLAVIX, Brilinta, Agranox, and Solostazole, if you've heard of any of those. And then the other category of blood thinners is what we call anticoagulation, and that works more for blood clots that come from the heart. And so those are medications like warfarin or Coumadin, and then Pradaxa, Eliquis, Xarelto. You probably see the advertisements for them on TV all the time. But those are the medications we'll use for people that have atrial fibrillation. Now, I just want to say something briefly about PLAVIX, because that was something that kind of opened my eyes a little bit when I started working in Hawaii. We've always were trained to know that some people do not metabolize PLAVIX properly, meaning they have a gene mutation that does not allow them to metabolize PLAVIX, meaning they're not going to get the full effect of the medication, so it's not going to thin their blood enough. And we know that it's much more common in Asians, especially in Chinese, and we've known that. But especially when I got here, I used to send a gene test to test this if someone was on PLAVIX, and it just turned out that a lot of the time I was finding that, especially with our large Asian population here, a lot of time I was finding that people had this mutation. So it's actually changed my practice in that I don't even use PLAVIX anymore for the most part in Asians because it worries me that I'm not going to know if it's really working for them or not. So I just mention it because it's important to know if you're on it, you want to know that the medication you're taking is actually working. So if you're on PLAVIX, and especially if you're Asian, I'd probably recommend you ask your doctor about it. And so I mentioned the left atrial appendage closure. So changing gears a little bit. So this is a procedure the procedure is putting an implant in your heart called the WATCHMAN device. So this is for patients who have atrial fibrillation, again, an irregular heartbeat, and we know that that type of irregular heartbeat can cause strokes, and statistically, the strokes from atrial fibrillation are more severe. And so the main treatment for preventing strokes from atrial fibrillation are the anticoagulation blood thinners. So those are the Eliquis, the Pradaxa, the Xarelto, the Coumadin. But like I said, some people, it's not safe for them to take those medications. So there's a procedure where we can actually, again, using a guide wire going through the groin, put a mesh in to seal off the part of the heart where the clots form and prevent those clots from leaving the heart and traveling up to the brain. So I'm going to just show a little video to kind of explain that procedure.
Nearly 1 out of 3 AFib patients will have a stroke. But why are they more likely to have a stroke than people without AFib? For patients with AFib, over 90% of stroke-causing clots that originate in the heart are formed in a structure called the left atrial appendage, or LAA. Everyone has a left atrial appendage. It is a small pouch that sits off of the left side of your heart. AFib may cause the blood being pumped through your heart to pool in the LAA, where it gets stuck and can form a clot. If that clot escapes and gets into your circulatory system, it can block the blood supply to the brain and may cause a stroke. Today, a number of treatments are available to reduce this risk of stroke. Blood thinners such as warfarin or Coumadin have been available for more than 50 years. But blood thinners affect the entire body and may not be well tolerated by everyone. They may have side effects like bruising, nosebleeds, gastrointestinal bleeding, or, more importantly, if the dosage is not properly maintained, an increased risk of hemorrhagic strokes. Plus, some blood thinners like warfarin require going to a clinic for INR checks and may incur out-of-pocket expenses. But there is a new treatment option that eliminates the need for long-term INR checks and the need to take daily prescription blood thinners. The WATCHMAN device is an implant-based alternative to blood thinners such as warfarin. The WATCHMAN implant is designed to permanently seal off the LAA, where blood clots can form. The WATCHMAN implant is about the size of a quarter. The implant does not require open heart surgery, and the device cannot be seen outside of the body. As in a stent procedure, your doctor will guide the WATCHMAN implant via a catheter through a vein in your upper leg and into the left side of your heart. Once there, your doctor will release the implant to seal off your left atrial appendage. The whole procedure typically takes less than 1 hour. You would then need to stay in the hospital overnight, and recovery typically takes about 24 hours. Over time, heart tissue will grow over the WATCHMAN implant, and the LAA will be permanently sealed off. In most cases, patients were able to discontinue blood thinners 45 days after their implant. The WATCHMAN implant offers patients with AFib a potentially life-changing stroke risk treatment option, which could free you from the burden of long-term warfarin therapy forever.
So if you have atrial fibrillation and your doctor says, you know, it's not safe for you to be on anticoagulation, then you should ask your doctor about this procedure. It's fairly new, so not everyone is aware of it, but it is a new treatment option we have if it's felt that you're not a good candidate for blood thinners. So I'm going to switch gears now. So there's something we call cryptogenic stroke. So that term means we don't know what caused your stroke, frankly. And surprisingly, we come across this a lot. So about 30% of the time when someone has a stroke and comes to the hospital, we do all the appropriate testing and we don't find the definitive cause of the stroke. It is felt that a lot of these patients might have atrial fibrillation that we just haven't caught yet. And because the problem with atrial fibrillation is it's intermittent, it can come and go. And so if you're not being monitored, you may never know you have it because it doesn't always cause symptoms. So we still don't know the best way to handle these type of strokes in terms of treatment. But what we do definitely, put a little bit more effort into looking for atrial fibrillation if you have a cryptogenic stroke. And so the ways we do that is so by doing long-term heart monitoring. So there's something, for example, called a Zio patch, which can stick right on your chest, It's basically like having a heart monitor with you. There's no wires. You can shower with it, but it stays there for 2 weeks. After the 2 weeks, you take it off and mail it in, and then we review it and see if you've had any episodes of atrial fibrillation. And again, the reason it's important is if we end up finding atrial fibrillation, we would have to talk to you about putting you on stronger blood thinners. If we don't find anything in those 2 weeks, if our suspicion is high enough that you might have atrial fibrillation, we might even refer you for something called a loop recorder or an implantable cardiac monitor. So this is a device that's very small. It's like a very small USB. It looks like one, and it basically gets implanted under the skin in your upper left chest. And it's essentially, the battery life lasts for 3 years. So it's basically like walking around for 3 years with a heart monitor. And you will, if you ever have any episode of atrial fibrillation or even any other dangerous type of irregular heartbeat, it would be picked up by this monitor, and you'll have a device at your bedstand, almost like that works like a cell phone almost, and will download all the data every 24 hours, send it to the cardiology lab, and then they can review it. And if there's ever a dangerous heart signal or heartbeat, it'll send an alert so that someone will be aware of it. So we'll send some patients for this if we think that their stroke looks like it's from an irregular heartbeat and we haven't caught it. Because we don't like to put people on those blood thinners unless we can prove for sure that they have the irregular heartbeat. Because again, those medications do come with some risk of bleeding. So I kind of mentioned the PFO'S. So again, the PFO stands for patent foramen ovale. So what it is it's a hole between the left and right side of the heart. And like I said, about 25% of the general population have one of these. It's something you're born with, and 99% of the time it's never going to cause an issue. But the reason we pay attention to it in strokes is it can be indirectly the cause of a stroke. So it's not the hole itself that causes a stroke, but if you have a blood clot in your legs, for example, the reason they tell you to get up every hour on the plane and move around is to prevent a blood clot from forming in your legs, because a blood clot in your leg could go up to the lung, and that could be very dangerous. But if you have one of these holes, one of those blood clots could travel up your leg and actually bypass the lungs by going through that hole and then get shot out into the circulation and go up to your brain and cause a stroke. So in some patients, if we think that their stroke may have happened in that manner, we might have to close their PFO. And it's a very similar procedure to the WATCHMAN procedure I showed you the video of. And it's essentially just a piece of mesh that seals off the hole in the heart there. It's the same type of procedure. It's not open heart surgery. It is a groin based procedure, just like the WATCHMAN. So that's pretty much, we covered a lot. So that's kind of like the treatments and what we do when you're in the hospital. After you leave the hospital, obviously, taking your medication, following up with your doctor, living healthy, that's all very important. And if you are unfortunate enough for us to, you didn't get there in time to have your symptoms reversed, or you still have some residual symptoms from the stroke, and you have some, you're not quite yourself, you have some, weakness of your right side, you have some trouble speaking, or your memory is not as good as it used to be, that's where rehab really comes into play. So by rehab, I'm talking about physical therapy, occupational therapy. That's really to work on kind of regaining your function, regaining your independence and your ability to kind of function on a daily basis and take care of yourself and be independent. Speech therapy to work on your speech, your cognition, also to work on your swallowing function. A lot of stroke patients end up having swallowing problems as well. So that's where the speech therapists come into play also. And so they really work on a lot of different things. Again, trying to make you get back to as close to, if not completely back to, as independent as possible. That's really the goal after someone has a stroke, is we want them to still be able to live an independent life, and that's where the rehab and therapy really is important. And that's just working on getting your balance and your walking, but also your arm coordination. A lot of different types of treatments we use for that, that the physical therapists use for that to try to kind of get your coordination and mobility back. I put in a little slide on acupuncture just because a lot of my patients ask me about it, and there is actually some long history of using acupuncture in stroke rehab. So there's really no harm to doing it, and I send a lot of my patients for acupuncture. So I think there's could be a good kind of complement to your physical therapy. So I guess the take-home points for today is just just how serious and widespread stroke is around the world and in Hawaii, and that time is brain. So I hope I showed you how important time is, and also I hope I showed how important it is for you to, really be aware that you have the, capacity to reduce the chance and minimize the chance of you having a stroke, and that also that, even if you do everything right, we can never make your risk of having a stroke zero. And if it does unfortunately happen, we do have much more treatment options and can offer treatment to more patients these days. So I hope you, take what you learned tonight, educate your family, your loved ones, coworkers, and hopefully don't have to use this information personally. Okay, thank you. And we'll open it up for questions.
All right. Thank you, doctor. Does anyone have any questions? We have volunteers, Tyler and Lon, who have microphones. Yes, raise your hands.
Thank you for the very informative talk that you shared with us. How important is it to, if you feel yourself having a stroke or possibly a stroke or maybe even a heart attack, to take aspirin right away, maybe even prior to calling 911?
So a lot of people, so the question is, how important is it to take aspirin if you think you're having a stroke? Honestly, it's not that important, and the reason for that is a lot of people do that. Most of the time it's not going to cause any harm, but remember, until you get to the hospital, if you're having symptoms of a stroke, we don't know if your stroke is a ischemic stroke from a blood clot or a hemorrhagic stroke from a ruptured blood vessel. So I have seen that before, where someone has taken aspirin because they're having stroke symptoms and their intention is good, and they get to the hospital and we do a CAT scan, and it turns out they actually are bleeding in their brain. And obviously you wouldn't want to take aspirin if you're bleeding in your brain. So I usually tell people it's probably not a good idea, and it's probably not going to help that much, because as soon as you get to the hospital, if you have a stroke and we think you need aspirin, we're going to give it to you right away. Yeah.
Oh, a while ago I was told that TPA cannot be administered until you get a CAT scan, and you can't get a CAT scan until you get to the hospital. So therefore, you can't get it in the ambulance because time is of the essence, as you said. Is that true? Still true?
So it is true that, yeah, we cannot give TPA unless we have a CAT scan. And the only way you're going to get a CAT scan is if you're in the hospital. So, yeah. So, I don't know if it's going to happen anytime soon in Hawaii, but there are now, around the country, there are a few places using mobile stroke units, which are basically ambulances that have CAT scans inside of them. So that might be something we might see in the near future, but not yet.
What do you think of a carotid artery scan as a screening tool? Because some places offer these things where you can, pay a couple $100 and get a carotid artery scan.
Yeah, we don't routinely check carotid arteries unless there's a reason to, meaning unless we think you're having symptoms from your carotid artery. We don't, it's not standard practice, or it's not really guideline based that we tell everyone to just screen yourself. You should have a reason to screen it. I think, just kind of telling everyone to get screened is probably not the right thing to do, because the vast majority of the time it will be fine. So we don't really recommend routine screening unless there's a reason to, meaning you have some type of symptom or you have some other medical condition that puts you at risk. So for example, the people that should be screened are people that have heart disease. If you have heart disease, it's probably a good idea to get screened, because like I said, a lot of the same risk factors for heart disease apply to strokes. So that might be a situation where you should get screened, but as just a rule of thumb to screen everyone, it's probably unnecessary.
Are there any statistics on how long it takes to recover, and whether the brain cells replace itself with strokes?
Okay. So in terms of statistics, in terms of how long it takes to recover, kind of most of the data suggests that the majority of the recovery from a stroke happens in the first 3 to 6 months. So for example, most of the clinical studies, when they're studying new stroke treatments, they look at how patients do 3 months after the fact, because that's felt to be when the majority of the recovery happens. But there's other data that suggested that really it's kind of up to 6 months actually. So kind of 3 to 6 months is the bulk of the recovery. But that doesn't mean that you can't recover after that. Some people can recover up to a year or more after a stroke, but the improvements there, you're talking about very small improvements at that point. The majority of the recovery is going to be the first 3 to 6 months. And in terms of brain cells replacing themselves, so brain cells do not replace themselves. What happens is actually people that do recover, the brain cells that die, they're dead permanently. So if you have a stroke, if we do another CAT scan or MRI in 20 years, you'll still see that same part of the brain damaged. But some of the surrounding parts of the brain can kind of rewire themselves, and that's how people get better. So they call that neuroplasticity. So it's not that the brain cells replace themselves, but the connections change in the brain. You kind of rewire a little bit.
You didn't mention the word heart murmur, and how is that related to strokes?
So heart murmur is a very vague term. So I get asked that question a lot, actually. So a heart murmur is not a disease. A heart murmur is when a doctor is listening with a stethoscope to your heart. If he hears a funny noise, that's what a heart murmur is. And there are some heart murmurs that are totally benign, and there are some that are dangerous. So it depends what's causing your heart murmur. So usually if your doctor sees a heart murmur, he's going to get an ultrasound of your heart or do some type of heart testing to try to figure out what's causing the heart murmur. But heart murmur by itself, it's not something that is associated with stroke, because a heart murmur can be from several different things, some of which are totally benign.
Okay, we have one last question here.
You mentioned something about a finger stick that you could check for your blood sugar, as a preventive measure. Where can I purchase some of these finger sticks from?
Sorry, did you ask where can you get them?
Yes.
That should be prescribed by your doctor, actually.
So you can't take it as a preventive.
So, but you should really only be doing that if you're diabetic. But if you're diabetic, then your doctor will be prescribing you something like that. Like it's not like a blood pressure cuff you can go buy at Long's or CVS, but finger stick that's something that your doctor should prescribe.
Okay, thank you.
All right, help for Dr. Salem.
Thank you.
Mahalo
Thank you.
to Val Milstein for providing our sign language interpretation.
Also would like to thank Jennifer Moran from the Queens Comprehensive Stroke Center, who was in the lobby earlier this evening, providing that great information, handouts, and talking story with everyone. And also mahalo to our Queens volunteers, Tyler Sharoma and Lan Nguyen. So our next Speaking of Health lecture here at Punch Bowl is called Brain Aneurysms, similar topic, and Advances in Treatment. Did you know that brain aneurysms can occur at any age? According to the National Institute of Neurological Disorders and Stroke, a brain aneurysm is a weak or thin spot on an artery in the brain that balloons or bulges out and fills with blood. It can burst, and 1 in 3 patients with ruptured brain aneurysms do not survive the first incident of rupture or bleed, with half of remaining survivors experiencing brain injury. Learn more with Dr. Samuel Sapiti, neurologist at the Queens Neuroscience Institute. He will talk about the presence and incidence of brain aneurysms, risk factors, identifying aneurysms through imaging, strategies for treatment, and recent advances and new technologies. That is Wednesday, June 26th from 6 to 7 p.m. here at the Queens Conference Center. It is free. You can register online at queens.org, click on Classes and Events, or call the Queens Referral Line at 691-7117. Thank you all for attending Queens Medical Center's Speaking of Health lecture. Don't forget to you don't need your parking validation because we're after 7 o'clock, and have a wonderful evening.